Welcome back to Med-Surg Knowledge Nuggets, where we take big nursing topics and break them down into manageable, test-friendly content. Today we're talking about cirrhosis. So before we get into cirrhosis, let's talk a little bit about the liver. So the liver does a lot for our body, over 500 functions, and this kind of categorizes them, but there are much more. So the liver detoxifies, it stores nutrients, it helps in our blood sugar balance, it metabolizes, it's part of our immune system, produces lots of different proteins, and it also produces cholesterol. And that's not everything. So you can pause to read this. This just gives you a little more detail on each of those things that I just mentioned. Okay, these are liver function tests that we would see on our lab work. And again, pause to read so you can understand what this test actually measures and how it relates to the liver. Here we have an anatomical picture of our liver, anterior view on the left. So we have two lobes, right and left. And then if you flip it over, the posterior view, you can see our little gallbladder hiding in there, which stores the bile that the liver produces. Take note that this blue vessel here is the inferior vena cava, and it is connected to our liver via hepatic veins. So the liver has a direct connection to our inferior vena cava, which is the vessel that carries blood back to the heart to be reoxygenated. So the liver is filled with millions and millions of hepatocytes. So hepatoliver-cytes cells, so lots of liver cells. And those cells are the workers. Those are the ones that are metabolizing, detoxifying, and producing those vital proteins. Okay, so now we can talk about cirrhosis. So cirrhosis is end-stage liver disease. If you have been diagnosed with cirrhosis, your liver is very, very sick. And by definition, this means that the liver has extensive degeneration and destruction of those hepatocytes or liver cells. You may have learned that liver cells can regenerate, which is true, but after recurrent inflammation, the tissue will become fibrosed and scarred, and then the liver can no longer regenerate. So this nodular appearance here is also part of end-stage liver disease / cirrhosis. So risk factors for cirrhosis: viruses such as hepatitis C. Alcohol, if you are a chronic alcohol user, it can damage your liver beyond repair, cirrhosis. Biliary disease, accumulation of fat in liver cells, genetic and autoimmune diseases. This picture here on the bottom shows 4 livers. The first one's healthy, and then it shows its progression from fatty liver to a fibrous liver to full-blown cirrhosis. The signs and symptoms that we see with cirrhosis are directly tied to all of those things that the liver is responsible for, but it's not able to do because it is so damaged. So I'm not going to read all of these now, but we're going to go through each one to explain why that happens with cirrhosis. So we do consider there's an early cirrhosis and a late cirrhosis. So early on, you don't have too many symptoms. Could be the patient's just tired, they're fatigued, and an enlarged liver may be seen on imaging, hepatomegaly. Liver function test may be normal at first. This means that you have compensated cirrhosis. Later, you're going to see more and more signs and symptoms as the liver begins to fail, and also due to portal hypertension, which we'll talk about in a couple minutes. So skin lesions, hematologic and endocrine issues, peripheral neuropathies, liver is going to become smaller and nodular. So these are a few explanations for a few of the things I just mentioned. You can stop and read those on your own, but we're going to talk more about these in the next slides. So now we're going to cover a few of the clinical manifestations and relate them to liver disease or cirrhosis. So you'll often see end-stage liver patients with jaundice. So jaundice is that yellowing skin color. You can see it on the skin, you can see it on the sclera of the eyes. So one of the reasons why this happens in liver patients is because the bile ducts that are supposed to transport the bile that the liver makes to the gallbladder become obstructed. And this is because of that fibrosed tissue. It compresses those ducts, and then there's nowhere for it to drain into, so it kind of just stays in our blood. So that's one of the reasons. Another reason is that the liver is supposed to process excess bilirubin, and as we know, the liver is not functioning properly, so that also plays a role in too much bilirubin floating around in our blood. Next, we have skin lesions. So this is due to extra estrogen that is floating around in our blood. So the liver is also responsible for metabolizing extra hormones that may be lurking in the blood. But if the liver is not working well, then that's going to lead to excess hormones. So in this case, we have spider angiomas, pictured here, and palmar erythema. So that is related to excess estrogen. Patients with cirrhosis may also have hematological disorders such as leukopenia, anemia, and bleeding problems. So the patient may have anemia that could be from possibly GI bleeding if they have esophageal varices or varices somewhere else. They can be nutrient deficient, so they may be anemic related to like folate or B12 deficiency, especially if this is due to alcoholism. Also, the spleen takes out red blood cells and the spleen becomes actually engorged with cirrhosis, and we'll find out why later. And then they also have bleeding problems, coagulation disorders, because the liver isn't able to make the clotting factors that it should be making. Also, because the spleen is engorged and not working how it should be, we also have low platelets because of that. Then we have peripheral neuropathy, so especially if the patient has alcoholic cirrhosis because they are deficient on many vitamins and nutrients. They can experience sensory motor symptoms like tingling, numbness, and sensory symptoms may predominate over all of those. Endocrine disorders, so we're talking about hormones. So we already talked about the estrogen part that's floating around in our blood, but it can also affect males and females a little differently. So in males, they can experience gynecomastia, which is increased breast tissue. They can lose axillary and pubic hair. Their testicles can atrophy. It can cause impotence and loss of libido. In women, they can stop having their menstrual cycle or experience vaginal bleeding. And one thing to note is that hyperaldosteronism can happen in a male or a female. So aldosterone is a hormone that acts on the kidneys that tells the kidneys to keep sodium and in turn fluid. So if you have hyperaldosteronism, that means that your body is keeping sodium, keeping fluid, and losing potassium. So complications from cirrhosis. So we may have compensated cirrhosis, and that's when we really don't see anything because the body is compensating for all of those changes. But eventually the liver won't be able to keep quiet and our body won't be able to compensate, and you end up with decompensated cirrhosis. This is going to result in portal hypertension. You're going to get varices, you're going to get edema, ascites, hepatic encephalopathy, and hepatorenal syndrome. So let's talk about why cirrhosis will lead to portal hypertension. So portal hypertension is a lot of pressure in the portal vein of the liver. So that is sitting about right here, if you can see my circle. So let's first name these structures before we get into it. So we have the liver, we have the gallbladder, we have the stomach, we have the spleen, we have the small intestines, and then we have our colon, which is our large intestine. And if you notice this big blue vessel back here, that is our inferior vena cava, pretty big vessel. And then if you notice inside of the liver, very vascular, lots of vessels going around there. And that's because it receives a lot of blood from these organs that needs to be processed, that needs to be detoxified. Once the liver does that job, cleans it up, it dumps it into the inferior vena cava, and then of course that blood is then brought back to the heart to get reoxygenated, and then it goes into the rest of the body. So the problem is that when you have a liver that is cirrhosed, you have a lot of scarring in there, a lot of fibrous tissue, and this vasculature here, all of these vessels, some of them become occluded, obstructed, some become narrowed. And if you combine that with the liver's inability because of those hepatocytes not working well, there's going to be a lot of backup. Okay, there's going to be some blood that doesn't get detoxified passing through because the hepatocytes aren't able to do it. And then if you have all of these narrowed, occluded vessels, the blood that is coming into this vein from all of these organs, it's going to get highly pressurized and backed up because it just can't get through fast enough. And what happens is these organs don't like that. They can feel there's something wrong. So they start to build collateral veins, collateral vessels. And these are veins that are going to bypass the liver because they're just trying to do what they're supposed to do. They don't know why it's so pressurized, but they know that's not right. So they build these collateral vessels, and instead of connecting to the liver, they just bypass the liver and dump into the inferior vena cava. They just connect straight to the inferior vena cava. So along with that, these organs can become enlarged. The spleen can become big and engorged, and along with those collateral veins, it's bad news. So that is portal hypertension. So let's talk a little bit about those collateral veins, aka collateral channels. So again, those are the veins that kind of are plan B. The organ just makes these new veins in order to get the blood out. And these can be in the esophagus, on the abdominal wall, in the peritoneum, and the rectum, also known as hemorrhoids. So those are really delicate veins, they're thin-walled, and they can bleed easily, which is why when patients have esophageal varices, you want to be really careful, and that's sometimes a contraindication to inserting an NG tube. So very fragile, bleed easily, and they are full of blood. So patients who have that nicked could actually bleed out and die. That's as much blood that can come out of there. And there's a picture right here of gastric varices. So this is in the stomach. So then something interesting here, there's something called caput medusae, where you can see like these protruding vessels in the abdomen. So this is related to, this is also portal hypertension. Everything gets backed up and engorged with blood. And this has to do with when we were born, our umbilical cord has two main vessels, and one of those, and they're closed off obviously, but those vessels actually become engorged, and it can lead to this Medusa-like appearance on the belly. So other complications from portal hypertension include peripheral and presacral edema. So this picture on the left here is an example of presacral edema, and then we have pitting edema on the right side on the feet and the hand. So this isn't only from portal hypertension. This could also be from the liver not making enough albumin. So what is albumin? Albumin is a protein made by the liver that helps to regulate oncotic pressure inside of our vessels. That means that it keeps fluid inside of our vessels. So if we don't have enough albumin floating around in our vessels become leaky, okay, and plasma will seep out of the vessels, and by gravity, that extra plasma is just going to fall wherever it falls. So it can often fall in the legs, can be in the arms, there in that presacral area, or even in our abdomen. So this contributes to ascites, also that abdominal fluid collection. And then the way portal hypertension plays a role is that everything is so pressurized that it literally squeezes plasma out of the vessels. You combine that with the low albumin, you just have a lot of plasma leaking out of all of those blue vessels from that previous slide. And then that is peripheral and edema, peripheral and presacral edema. Okay, ascites. So I just mentioned a little bit about ascites. So what causes that? So by definition, this is accumulation of serous fluid in the peritoneal or abdominal cavity. There are a few things playing a part in the development of all of this fluid just sitting in the belly. So first, we just covered portal hypertension. We don't have enough albumin, we have leaky vessels, there's a lot of pressure there, and it squeezes out all of the plasma. Plasma just falls where it falls. It can end up in the legs, or it can end up in our abdominal cavity. Hypoalbuminemia, we just mentioned that, and then we have hyperaldosteronism, which I mentioned before. So aldosterone is a hormone that works on the kidneys to help maintain our fluid balance and our blood pressure. So if we have too much aldosterone, then we are going to keep sodium and keep fluid. And patients with cirrhosis tend to have too much aldosterone because the liver isn't taking it out of circulation. That's one of the things it's responsible for, and it's not doing it. So this is causing water retention. So this is just adding to the problem of all of that fluid collection in the abdomen. So patients can have signs of dehydration. Remember, they're fluid overloaded, but their vessels are dry because the fluid is actually in the tissues. It's not really in the vessels because they're leaky, and it's just kind of sitting in the extremities and in the abdomen. So the patient will have signs and symptoms of hypovolemia or dehydration, like a dry mouth, sunken eyeballs, muscle weakness, and decreased urinary output. So low potassium is common, and that is because the patient will probably be on a diuretic. So that doesn't, something like furosemide will cause you to lose potassium. But also because of the hyperaldosteronism where we are keeping more sodium, remember sodium and potassium have an inverse relationship, so we will be losing potassium that way also. So one thing to note is that these patients with ascites have a risk for spontaneous bacterial peritonitis, or SBP for short. And this is where that abdominal fluid becomes infected with bacteria. So it can happen spontaneously. Studies have shown that this happens sometimes when there's bacteria that's in our gut, kind of makes its way to the fluid, and then that infection actually comes, from us, from inside out. Sometimes this comes from a paracentesis where they're going in to drain that fluid, and whenever you're sticking anything into the body, a drain, an incision, there's always risk for infection. So spontaneous bacterial peritonitis is life-threatening. That needs to be treated right away. So let's talk a little bit about paracentesis. So this is an invasive procedure. It's done by the provider. We do need a consent. The patient should empty their bladder before. This can be done in a supine position or a semi-Fowler's position, but if the patient's able to sit, like here, then that would be the preferred position. When they're sitting up like this, the bowels kind of float, and then it's easier to get like a big pocket of fluid at the bottom that they can take out. So once they do this, you want to monitor for hypovolemia and electrolyte imbalances, because this is a big fluid shift. Even though the fluid in their abdomen is not really working in our circulatory system because it's not in our vessels, it can still cause electrolyte imbalances, electrolyte shifts. So we just want to keep that in mind. We want to monitor their blood pressure and heart rate. They are high risk for bleeding because remember, any liver disease patient is going to have prolonged bleeding because the liver is not making those clotting factors as well. So we're always going to check for that. And then you, just like any other puncture and incision, you want to make sure you're monitoring that site for bleeding, leakage, and making sure that dressing stays clean, dry, and intact. So management for ascites. Patients should be on sodium restriction because sodium brings fluid, retains fluid, and we don't need extra fluid. Patients will be on usually 2 types of diuretics, a potassium-sparing diuretic combined with a loop diuretic. So it would be like furosemide with spironolactone. And spironolactone will work in 2 ways. It's a diuretic, but it is also an aldosterone agonist. And that is perfect here because this patient has too much aldosterone. They may also benefit from albumin infusions. Paracentesis is as frequent as twice a week sometimes. When patients have ascites really bad, liver failure really bad, that fluid accumulates pretty quick. They may fit the criteria to get a TIPS procedure, a transjugular intrahepatic portal system shunt. This is where a shunt is placed at the portal vein that pretty much bypasses all of that fibrous tissue so that more blood can get through the liver. The problem with that is if you use a shunt like that, a lot of that blood isn't getting detoxified. So you end up, yes, decreasing the portal hypertension, but then you're allowing this, I'll just say, quote, dirty blood to get into circulation via the inferior vena cava. And then there is a peritoneal venous shunt, which again is kind of a similar idea. Hepatic encephalopathy. This is another complication from cirrhosis. So this is a toxic effect of ammonia. So why does this affect liver patients? So where does ammonia come from? Ammonia is the byproduct of protein breakdown, and it's the liver's responsibility to take the ammonia and then convert it in, or break that down and convert to urea, which could then be excreted by our kidneys. Again, if the liver's not able to do its jobs, that is not going to happen. So you end up with lots of extra ammonia in the blood. Ammonia crosses the blood-brain barrier, so that is why we're going to see these neuro symptoms with high levels of ammonia. When a patient has hepatic encephalopathy, you will see altered level of consciousness, inappropriate behavior, trouble sleeping, concentrating, and as the ammonia levels rise, patient can go into coma and die. So this is something that would be a priority for us. This is a priority patient if they have hepatic encephalopathy. We really want to monitor their orientation, their alertness and their orientation. They can also experience something called ascites, which is like flapping tremors, and it's most commonly seen in the arms and hands. So if the patient sticks out their arms straight forward, they have this involuntary movement. It kind of looks like flapping. So you can do that and try to assess that with your patient. So what are we going to do for this? We need to get the ammonia out of the body. We need to lower those ammonia blood levels. This can be done in a few ways. Lactulose. So lactulose is a type of sugar. If you ever tasted it, it's very sweet. It is an laxative, but it also traps ammonia in the gut, and then it comes out as stool. So this is a PO medication. It can be given through an NG tube, by mouth, even via enema. So patients that have hepatic encephalopathy will often be prescribed lactulose, and sometimes it's on a maintenance type prescription where the patient just takes it every day, whether they have it or not, to make sure that they don't get it, to keep the ammonia levels in check. So those patients will have diarrhea, but that's not what it's being given for. It's not given for constipation. It is given to reduce the ammonia in the blood. Rifaximin is another option. It is an antibiotic, but it does something similar to lactulose. But sometimes patients can't tolerate lactulose. It's kind of, you have to take it by mouth, and it can be not easily swallowed. So rifaximin is another option. Lactulose and rifaximin are even sometimes prescribed together when patients really have a hard time controlling those ammonia levels. There's also neomycin. This is a broad spectrum antibiotic that can also help in some cases where it helps to break down the production of the ammonia, but that's not going to be the first choice. We want to prevent constipation, so we want things moving so that all of that ammonia can come out. We want to also avoid protein overload because ammonia is from protein breakdown. So patients who tend to become or to have hepatic encephalopathy should limit their protein. Very, very important that you don't limit protein on every liver patient because we need protein. The liver needs to make protein like albumin. So if we don't have the building blocks, then we start other problems. It's only with patients who have a tendency to have this hepatic encephalopathy is where we want to be careful with protein intake. The other patients, protein is actually good. We want to control GI bleeding because blood is protein. So if you have GI bleeding, it's going to become digested, and then we're going to have lots of ammonia. So as the RN, you are going to monitor those ammonia levels, and because a patient could have lots of diarrhea, loose stools, then we're also going to monitor for fluid and electrolyte imbalances. Okay, in this video you can see a patient sticking out their arms, and that little movement there, that involuntary movement, is ascites. That's involuntary movement. The next complication is hepatorenal syndrome. So this is when you have a patient with cirrhosis, with end-stage liver disease. They didn't have any kidney problems in the past. They had healthy kidneys, but then now their kidneys are beginning to fail, and it's all because of the liver. So this is going to be renal failure with azotemia. Azotemia is a buildup of toxins in the blood. Oliguria, which is decreased urine output, 400 mLs with over a 24-hour period, and intractable ascites. So intractable ascites means that the abdomen keeps filling up with fluid, and despite all measures, it just keeps going. It's like a big cycle. Nothing we can do about it. So there's no structural abnormality of the kidneys. Again, they were healthy. It's the liver's fault. And this is due to portal hypertension. So that really pressurized portal vein, everything is squeezed out. It's going to cause oxygenation issues, perfusion issues. So it's going to lead to issues with the kidneys getting their own oxygenated blood, which then impairs the kidney and leads to renal failure. The only cure is going to be with the liver transplant because the liver is the problem. And one thing to note, in the patients with cirrhosis, this syndrome frequently follows diuretic therapy, GI hemorrhage, or paracentesis. Diagnostic studies done for cirrhosis. So we are going to do labs, and we will see elevated liver enzymes, so increased ALP, AST, and ALT. And at the beginning of this recording, there was an explanation of all of these. We'll see increased bilirubin, decreased albumin, decreased platelets, and prolonged bleeding times. A definitive diagnosis can be made with a biopsy, a liver biopsy, percutaneously. So you can see in the picture, this one's under ultrasound guidance. Post-procedure, you as the RN should advise the patient to lay on their right side to put pressure on the puncture site and to prevent bleeding. They may have a sandbag over that site. Remember, the liver is very vascular, so we don't want it to bleed. And these patients are at risk for hypotension and bleeding, so you want to make sure you're assessing your vital signs. So this is a picture of that TIPS procedure. We mentioned it a little bit before. Some patients might meet the criteria to have this done if they have cirrhosis. And you can see that there is a shunt place that connects the portal vein out the hepatic vein. And again, the problem with this is, yes, it increases blood flow, so the portal hypertension will decrease. However, there's going to be blood that bypasses the filtering process. So there's going to be a lot of blood that goes through and doesn't get detoxified and will go into circulation via the inferior vena cava. And patients that have this done are at higher risk of developing hepatic encephalopathy because this blood is being bypassed and it's not being cleaned. Final nugget of knowledge for cirrhosis. So the main takeaway from this would be for patients with cirrhosis, you as the RN should be monitoring for bleeding because with impaired liver function, that puts them at risk for a prolonged bleeding times. You want to watch out for signs for hepatic encephalopathy, which is going to be confusion, asterixis, and this is of course due to that ammonia buildup. So you want to make sure that the patient is safe. You want to continuously assess for fluid overload, ascites, which means you're going to monitor for daily weights, abdominal girth, and also their respiratory status. These patients need good nutrition, so they need education, they need to take their medication, so medication compliance, including lactulose and diuretics, because that is going to help manage their complications and prevent, hopefully, worsening liver function. Thanks for watching. If this helped clarify things for you, make sure to like, comment, and subscribe for more Med-Surg knowledge nuggets just like this one. See you next time.